Subscribe to our YouTube channel and press the bell icon to get the latest updates.
I'm with Professor VijayRaghavan, Scientific Advisor to the Prime Minister, a former Secretary in the Department of Biotechnology, a specialist in genetics and neurogenetics. Professor, welcome to ThePrint.
Thank you.
So my first question is about the status of positive COVID cases in our country. Crossed 110,000, about 3,500 deaths. What are your comments?
Since the time the pandemic was declared, and even before that, when the WHO declared a public health emergency alert of international importance in January, India took extraordinary steps about curtailing passenger traffic, international traffic into India. And subsequently, multiple other steps have been taken right now. Now, the result of all of that has been, in terms of what was predicted at that time, a substantial lowering of both cases and mortality. And now, as we go out of the lockdown, our challenges are really about how well this time has been utilized to build up our capacity so that as we go into opening up the economy, we are able to cope with cases which arise particularly in different parts of our country.
So are you concerned that the cases are going up? Much more than China than in India today.
Right. The question really needs to be posed in a country as large as India, or for that matter, China, not about what the country as a unit does, but what different components are doing. So we should ask at the level of states, districts, cities, crowded parts of cities, what's happening, because it's at that granularity where things need to be attended to. And there you will find different kinds of problems and different kinds of solutions for each context. So a very crowded area in a city where some small number of cases are growing up might require much more attention than a perception which might come from an aggregated look at an entire state or the country.
But you're not saying whether you're concerned or not. So are you concerned?
Well, in diseases like this, one must always be concerned. One should not be complacent. And we've learned those lessons even from Korea, where there's been extraordinary control. Also what's happening in China now, where the pushback and the resurgence can happen from a very small number of cases. It's important to keep in mind why this happens. It's not that, here are a number of cases and therefore we should be concerned or not. But we know now that the spread takes place not by the total number of cases being important, but some of these cases spread much more. Why do they spread much more? It's not that something is there in that person who's spreading it, but it's also in the context. Long, intense conversations in closed environments with multiple people, with one person positive, can have an extraordinary impact, but several people positive distributed outside, away from each other, may not have that impact. So it's really not the total number alone which is a matter for concern, but the potential for exponential growth in certain circumstances.
Right. So let me ask you, this novel coronavirus that we're dealing with, SARS-CoV-2, where did it come from? It came from Wuhan in China, but did it come from a lab? Did it come from a wet market in Wuhan? Where did it come from?
It's important from the perspective of biology in many ways to understand this. Viruses require cells of various animals, these kinds of viruses, to replicate. And the bat is an extraordinarily good laboratory, as it were, for this virus. It's a warm-blooded animal, it's a mammal, and therefore when the viruses infect these, in principle they can grow quite well, as in other mammals. But the bats are particularly interesting because they fly a lot and they have extraordinary high metabolism. And that allows these viruses much nicer conditions than they would otherwise get. Why doesn't the virus infect the bats? Because the bats have calibrated their immune system so that they have it just right so that they don't get infected, but they also don't overreact and get affected hugely. So bats are a great reservoir. Now, humans and bats have interacted for thousands of years.
Right.
And they do that not just in wet markets, but in caves, in places in people's homes, in large buildings. Bats are all present. And this kind of interaction takes place a lot. Pandemics don't happen only because of these kinds of interactions. But when these interactions happen over a very long period of time, there's a very likelihood that some unusual event might happen which allows the virus to jump from bat to human. Wet markets are an area of intense interaction, and therefore those are particular areas where these kinds of things happen.
So do you think it came from a wet market?
All the evidence points to that kind of an interaction.
So you don't think it came from a Chinese lab in Wuhan or?
Well, there is no evidence for that. Looking and how does one judge that? One looks at the sequence of the virus, and then one goes back and looks at the genetic sequence of these kinds of viruses in bats and in other kinds of bats in other locations. All the evidence points to a bat origin, as it were. Now, you can always hypothesize that the bat was taken to the lab and so on and so forth. But the simplest explanation now is a natural one. The WHO has agreed to look into this matter in some detail to see exactly what happened. And there's a lot of good detective work, biology, ecology, looking at evolution, which can address this question better.
So coming back to India, you talked about gene sequencing. Now this strain that we have here in India, to explain to a lay audience, is this the same strain that exists, say, in the US, in Europe, and other parts of the world?
No, wherever it came from, we know it came from Wuhan, then it went to Europe, let's say, then it went to America, and it came from Wuhan, from China to here, from Europe to here. All of that can be done by tracking the sequence of the virus, in addition to tracking individuals.
Right.
But remember that almost all, as far as we know, all those changes now are in regions of the string which do not affect the functioning, the fundamental functioning of the virus, as far as we can tell, in any significant way. And therefore, we cannot say whether the virus in its travels has become more infective or less or not. It doesn't look like.
Or less virulent.
It doesn't look like.
So, Professor, tell us a little bit about the model that you are using, that the government is using to predict how the virus is how these cases are growing.
Remember that, in any case, the important thing which has happened increasingly as the disease has progressed all over the world, we are moving from predictions with very little information from the rest of the world and India to much more information-based approaches at the district level, at the city level, and so on. So at that level of granularity, there are very rapid decisions now which we are taking.
Like in what way?
Well, for example, what would you do if there are 5 cases in Dharavi? How would you contact trace? How would you isolate? How would you, treat? So those are very important local decisions. So decisions start moving from an early stage where you say nationally this is what we need to do, to at stages like now where local governments are NGOs, citizens groups, cities, state government, center, all need to act at different stages of local functioning. That poses both enormous range of solutions, because if you address certain things well, you can take care of things quite well or reasonably, and also it poses great challenges because of the diversity of our context.
So since we're talking about Dharavi, you mentioned Dharavi, and Dharavi accounts for about half the cases in Mumbai, certainly, perhaps even in Maharashtra. So what is the Dharavi, what does that teach you? What does that tell you?
This is what I alluded to earlier about looking at the nature of transmission. And these are lessons which one constantly learns. But it points to a situation that transmission takes place more frequently in situations where people are in prolonged contact with each other, or short-term intense contact. So imagine in places such as Dharavi, there are many other such places, several thousand people share a toilet, they share a bath, and in rooms several people work together, so live together and across age groups. So that poses an enormous challenge when something starts in that area, and it's not easy to stop it, but it's practical to deal with it in sensible ways, and people have to dynamically do that. And it has to be both top down and bottom up.
Talk to us a little bit about the immune response. 3,500 deaths, which all unfortunate, of course, but India has dealt with it better than some other parts of the world.
Again, just as I would not get worked up about specific areas of intensity, but focus on dealing with those areas, similarly, one should be careful about putting in comparative studies. India better than X country, some other country better than India, and so on. Right. This is not the Olympics, right? This is about a disease about which we are learning a lot as we go by. And the fraction of people who are infected, who have the disease, or the fraction of cases who come up and who die, right? Those are numbers which are very important. They're indicative. They tell you what to do, but those are not a medal or a loss of a medal. They are very important insights to tell you what to do. In that situation, it's important to keep in mind that what is the meaning of these deaths? Who are the people who have died? How old are they? What were the exact circumstances which led them to die? What was the kind of presentations they had before they died? Those who survived, how did they survive? What was the age distribution? Their other background. This data hospitals are looking into, and the Indian Council for Medical Research and the Health Ministry looks into. That gives a better picture objectively about this. Now, couple of points about the disease and immunity itself. We are learning a lot now, but we still don't know a lot. We don't know, for example, how resistant people are to infection, for how long, after they have recovered. Indications are that they are perhaps likely to be resistant for a long time, because people who had SARS-1 more than a decade ago still have what are called neutralizing antibodies, and this is a similar virus. So the hope is that this too will provide long-term immunity. But does that vary from people to people? Does everyone show long-term immunity? Do people who are more severely affected more immune later on when they recover? We don't know. We'll find out all these things.
So are we in a stage of community transmission?
Well, you asked earlier about people coming from abroad, and then you asked how it moves, and it starts moving intensely there. Now, the fact that you're seeing people, what does community transmission mean? People mistake it for, does a community have it?
No, not a community, but
it means simply that it has come from the community as distinct from your identifying an individual who brought it. When you don't know that individual who was the cause of someone getting infected, who passed it on, then you say it's come from the community, right? And now you've said that, you've seen, as you said, the migrant workers taking it from one location to another, and you've had other kinds of cases spreading in Mumbai, for example. So those would be local effects which fall into this term. Now, to move that and say India has community transmission or not, gets into a binary which is a different kind. So we have to look at this again locally.
So when you say locally, would you say then that Dharavi has community transmission or Mumbai has community transmission? Just a couple of examples.
I haven't looked at the specific data, but it looks like the transmission there is a local transmission, and in many cases you wouldn't know what the chain was, and therefore you will have to say that yes, it's moving in the community.
In Mumbai?
In Dharavi, for example, or in Mumbai, yeah.
There's been a lot of debate around, the Indian population being exposed to a lot of infections from childhood, and that is perhaps one of the reasons. And a part of that is also the BCG vaccination that we have got. So would you say that this exposure to infection has enhanced India's immunity to dealing with SARS-CoV-2?
From an immunological perspective, it's not clear how exposure to other diseases increases or lessens your immunity to SARS coronavirus 2. Okay. The immune response is a property of the individual's genetic background and the parents, the mothers particularly, state while the fetus is growing and the environment in which the child develops. So lots of early components set the immune response. Quite often, burdens of disease early on in the mother or in the child can actually result in an immune response which is set at a lower level, right? The exposure to disease, which many talk as being valuable in immunity, is really something which they mean is very valuable in allergic responses of various kinds, where exposures of various allergens tend to lessen your having allergic diseases later on. So it's not clear that having a greater disease burden somehow enhances your immunity. That's not evident at all. Now, BCG you mentioned. Yeah. Now, BCG is effective both in, against childhood tuberculosis and has been shown to be effective in some other contexts. Typically, the effects of BCG wear out into adulthood. So, and this disease affects, adults, and we have seen the burden of the disease in India and in many other places where there have been BCG vaccinations. There have been interesting correlates in some situations. People have said that one country which didn't have vaccination and one which did, neighboring countries have differences. Very interesting correlation, but given the lack of preponderance, continuation of the BCG immunity, that hypothesis needs to be investigated. So people are doing trials on that, and we will know whether that's meaningful or not.
Right. So last few questions, Professor. One is, you mentioned about the mother and child. So would COVID pass from mother to child?
I don't know. There have been some reports recently of many pregnant women who are positive, who gave birth to children who were negative. So at least those instances which I know of doesn't suggest that it's a requirement.
Right.
But whether there are some other ways by which it can happen or not, we don't know.
Okay. Tell us a little bit about the vaccine trials. There are about 8 ongoing trials in the world. How soon do you think we can get a vaccine? What is the status of some of these?
Well, there are actually more than 100 attempts all over the world.
Okay.
And there are about 20, 30-ish attempts in India. And this is important. Typically, a vaccine takes about 10 to 15 years to make and costs about $200 to $300 million. The world is trying to do this in 1 year, and the cost will have to be about a few $1 billion for that. How do you do something which takes 15 years in 1 year? You do this by doing many things which you do linearly all together. So you develop a potential vaccine, you skip an animal trial, which if you don't need it, essentially, you go into human trials. But as you're going into human trials, you manufacture the vaccine in large amounts and you stockpile it. Out of 100 vaccines, 2 or 3 will succeed. This manufacturing is likely to go waste. But if it doesn't and you luck out and this is valuable, you have a stockpile. Right. So you have to invest in that. You have to invest in parallel trials. You have to, do things at a global level really fast. So people are trying multiple approaches to vaccines, and that costs a lot, and the whole world is coordinating. Remember that India is a huge manufacturing powerhouse for vaccines. every child in the world who gets 3 vaccines, about 3 vaccines, 2 of them are made in India. So India will be normally a major source of providing vaccines both to India and the whole world. But Indian companies and Indian academia have done something extraordinary in addition, which is to work at the early stage at vaccine development in a manner which is quite extraordinary. Every single Indian vaccine company, many of our startups, many of our academic labs are working on different types of vaccines.
Including one for this.
Oh, I'm talking only about COVID-19.
I see.
Yeah.
So how many would there be ongoing inside the country, in our country?
I said about 30, of which I would put about 10 of them of being quite high quality at this stage.
And how long do you think this will take?
Again, just as you asked about which country is better, which country is worse, this is not a race for the following reason. Supposing someone makes
a vaccine. It is a race, Professor. A lot of people are talking about it as a race.
It is a race in terms of getting it to people.
Yes.
It's not a question of who made this first.
No.
But having made it, right, getting a vaccine through, the manufacturing and distribution, the access is a huge challenge. And therefore, it's more like a marathon rather than a sprint. Someone comes in, gets the vaccine going, manufactures 100 million doses, gets it going. Second person comes, another 100 million, 500 million doses there. There's going to be constant room for innovation and vaccine development because fundamentally, remember, a vaccine is not like a switch that it treats people. How do you deploy it? How effective is it? Is the vaccine which worked really well in the trials, is it working on the field? And therefore, someone who's number 7 might end up making a vaccine which is much, much more effective than 1, 2, 3, 4, 5, 6.
So which are give us a couple of Indian names that are working on this?
Well, I'll tell you first what the kinds of vaccines people make. They take the genetic sequence and basically inject that itself, so that sequence makes some of the viral proteins which serve as an immune response, and so when the disease comes, then you're safe. Another way is to take some other virus as a vehicle, its sequence, and put this virus's genetic sequence inside, and then raise a antibody against that. So that's another kind of a vaccine. Typical vaccines for a long time have used an attenuated, a weaker form of the virus and injected that.
Sure.
Some people are trying that out, right? So these are the multiple kinds of approaches people are taking. Now, our vaccine companies, except for the first one, which I said we put a genetic sequence, and then look at its expression and raise a vaccine, which is new for anywhere in the world. If that's the Moderna one, if that succeeds, that will be a new kind of vaccine. Our companies are very good at dealing with all the other kinds of vaccines, and they will be up to speed for the first one also. Our major vaccine players are the Serum Institute, Bharat Biotech, Biological E, right, Cadila. So there are several other companies, smaller ones, which are important.
So all these are working on a possible vaccine?
Well, they're each working on at least 1 or 2 vaccines. In addition, many of our startups have done really well.
But you're still not willing to put your money on how long it'll take before you and me can inject ourselves with a vaccine that will...
I hope you and I don't need to inject ourselves until many others have. Even though I'm well above 60, frontline workers and people who are vulnerable need...
Absolutely. No. When I say you and me, I mean ordinary people like us.
So I think there has to be a tiring in the way...
I'm sure that will be. There will be a tiering.
So that deployment will take at least a couple of years to go and reach everyone. And remember, this is also a major challenge. Unlike other vaccines, which typically are childhood vaccines, you want to give it to the entire population. So you're talking about billions instead of millions, hundreds of millions. Yeah. So this is an enormous challenge. That's why I'm saying we must focus not on putting our bets on any vaccine, but looking at the failure rate of vaccines everywhere, invest in parallel in multiple vaccines, because we must be cautious as well as optimistic that some things might succeed, but if they succeed, good, we need a better one. If they don't, we have something else coming. Right. So a parallel pipeline is very important.
But that would also mean to me that the people would also need a constant flow of information coming from sort of, in the scientific community.
Absolutely. You have hit the most critical point. And whether it is, our crowded areas or jobs or what to do while we wait for a vaccine, we need two processes. One is from the science end. What do we do with the virus in terms of drugs and vaccines? And the other is what do we do with us? And what we do with us is as much our role as, statements coming from above. And communication is very important there. And that communication, I can't stress how important it is. If we, even in the absence of a vaccine or a drug, while we're waiting for it, if we follow masks, hygiene, distancing, these are in our hands, right? And then testing and tracking are not entirely in our hands. Then we would have really, crunched the virus enormously.
Professor VijayRaghavan, thank you so much for this wake-up call and for at least a peek into the deep dive that SARS coronavirus has opened up for us. This is Jyoti Malhotra for ThePrint. Please continue to watch our YouTube channel and follow us on social media.